talk is going to be by Dr. Somasheila Murthy. She has sent a recorded talk and she would be joining in shortly. Uh, Nikhil, can you play it from your side or do I have to play it? I think I have.
Great.
Hello everyone. I thank the All India Ophthalmology Society to give me this opportunity to present a talk on the update in the management of peripheral ulcerative keratitis. So what is peripheral ulcerative keratitis or PUK? It's an extremely rare inflammatory condition of the eye which can be associated with systemic autoimmune diseases. Collagen vascular disease association occurs nearly in 50% cases, and the ocular manifestation can actually be an initial presentation of celiac disease. So what are the clinical features of PUK? It can be unilateral or bilateral disease. The classical picture that we would see would be a crescenteric perilimbal corneal ulcer with subepithelial infiltrate at the edge of the ulcer, as can be noted in this clinical picture of a patient with peripheral ulcerative keratitis. You can also note here that the adjacent conjunctiva and perhaps even the sclera shows inflammation. The ulcer progressively spreads both centripetally as well as centrifugally. There may be contiguous involvement of the conjunctiva, episclera, and scleral tissue, and occasional anterior chamber reaction, as can be seen in this clinical photograph. So what are the causes of peripheral ulcerative keratitis? We can divide the causes as either local, which are isolated and occur in the eye alone, or those causes which can happen in the setting of a systemic etiology. In these cases, obviously, we would have to detect the systemic disease because some of these diseases have a high morbidity and mortality associated with them. Also, some of these diseases can have a rapid progressive course leading to perforation in the eye, which is an ocular emergency. So, to manage the disease is to locate the etiology. Coming to the local causes, we can divide them as infectious causes, which include bacterial, fungal, viral, as well as parasitic, and non-infectious causes, which include post-trauma, the problems that are located in the lids and lashes, neurogenic causes, local autoimmune diseases such as Murins. Coming to systemic causes, we can have diseases such as dermatological, inflammatory bowel disease, malignancy, or even certain systemic infections can manifest with PUK. Let us look further at the local causes of either PUK or PUK-like picture. These can be subdivided as infectious and non-infectious causes. Amongst infectious causes, we can have various organisms which can lead to bacterial corneal ulcers, and amongst them it can be staph, streptococcus, or gonococcus, moraxella. So these are some of the bacterial organisms which can cause peripheral thinning and can resemble PUK. Viral disease such as herpes simplex and herpes zoster are well known to occur as marginal keratitis, and these can once again resemble PUK. Both acanthamoeba and fungal keratitis can initially present as in an atypical form as a peripheral ulcerative. Coming to some of the systemic causes, the immune-mediated causes of PUK. These include autoimmune disorders such as rheumatoid arthritis, Wegener's granulomatosis, and many other such diseases, even certain dermatological conditions, and the list goes on to include inflammatory bowel disease, and as well as systemic infections, which I had talked about a little bit earlier. In addition to cases which have local form of PUK, for example, these two examples, one of them is HSV necrotizing keratitis and the second is ocular surface squamous neoplasia. So these would include either microbiological investigations in the first instance, or in the second instance, we might resort to doing a impression cytology of the surface, and therefore we can rule out an infectious etiology or ocular surface problems and rare causes such as even OSSN. How about the differential diagnosis? So once again, we can have various causes and we can classify them as inflammatory, degenerative, those associated with disease contiguous to the cornea, as well as neoplastic, as I showed in the previous slide, and metabolic diseases. So the gamut of conditions that can lead to a peripheral ulcerative kind of picture can include Morin's as something as severe as Morin's ulcer, or something as mild as a peripheral corneal infiltrate, as seen in contact lens patients. Sometimes you can have certain other diseases of the eye resembling peripheral ulcerative keratitis, and I'll come to that a little bit later. So these are a couple of examples of patients who very different etiologies of PUK. The first is an example of a patient who had bacterial keratitis, and with rapid advancement of the disease, patient developed a perforated bacterial corneal ulcer. When the patient came to us, we did scrapings from the edges of this ulcer and also took up the patient to apply tissue adhesive on this perforation, but that didn't succeed actually, because subsequently we did a corneal patch graft for this patient. On the other hand, we have a patient with a very advanced Morin's ulcer, and you can see that almost the entire cornea is affected. There's only a small amount of residual stromal island remaining, and the peripheral area is extremely thin with staphylomatous formation. The other causes of PUK-like picture, and we should not miss these, are cases of dry eye, especially keratoconjunctivitis sicca. So how do you differentiate between this condition? You can see the pictures of the right and left eye of a patient who we diagnosed as severe dry eye or keratoconjunctivitis sicca. So look at the lack of luster on the cornea, as you can note in the slit lamp images of both the eyes. And in addition, in the picture on your left also shows peripheral sort of a thinning and a Dellin effect, as well as some infiltrate at the edge of it. So these patients are not the conventional peripheral ulcerative keratitis, but these are all changes secondary to lack of wetting in this particular instance. And the left eye, when we stain it, can pick up the areas which stain very well. The lower lid reflex shows a very low lower lid tear meniscus for this particular patient. Other example of a patient with secondary Sjogren's and presents to us with the right eye showing severe dry eye, and in the left eye there's peripheral vascularization and a focal area of thinning, severe thinning with iris perforation, with iris plugging it, leading, which is a perforation. So sometimes these patients can be missed and can be instead diagnosed as peripheral ulcerative keratitis, and the dry eye can be missed. So we must always be very careful in examining the ocular surface for all of these patients. These are other examples, more benign versions of what we can miss and what we can pick up as PUK or healed PUK. So these are not cases of inflammatory etiology, but this is a patient with Terrien's marginal degeneration. So what you can note, especially in the slit, is the peripheral thinned out area, and the advancing portion shows whitish lipid deposition. And if we look at this patient on slit lamp, we would also see a lot of vessels in the peripheral area. So this is a patient, it's usually a bilateral condition. This is the picture of another patient of Terrien's marginal degeneration, very advanced with a lot of lipid kerati. This is another classical example of Terrien's with lipid deposition at the advancing portion of the peripheral thinning. So sometimes these are often referred to us as Terrien's. Terrien's are often referred to us as resolved active PUK. So this is in fact two pictures. One is this particular patient actually has old scleritis with peripheral ulcerative keratitis, which has now resolved, and the patient is doing well with treatment, with therapy. But however, because of the vessels, the patient has lipid deposits. A very close looking differential diagnosis, but because we have history and treatment history for years of the scleritis, we know that this is not Terrien's. So how do you rule out infection? It's critical to differentiate between the two, because the mainstay for therapy for non-infectious is steroids, and some of the infections we cannot use steroids, for example fungal keratitis. Also, if it's non-infectious, we know that the gravity is more, because about 50% of these can be associated with systemic collagen vascular disorders. So therefore, this distinguishing between infectious versus non-infectious is extremely important. Remember that among the infectious, you can also have viral etiology, the HSV, varicella zoster virus, bacteria, as well as fungi and acanthamoeba. So we need to do an infectious workup for these patients. The second differentiation we need to make, especially in the case of Morin's ulcer, is to differentiate from other causes of PUK with scleritis. So here's a patient on the right side with scleritis, and you can see that the entire eye looks extremely congested, whereas in Morin's ulcer, it's gradually progressing and does not involve the sclera. But both these conditions require referral to a higher center and co-management with a rheumatologist or a physician. So the management of PUK also depends on at what stage the patient presents to us. In the case of Moran's ulcer, we often resort to resecting the inflamed conjunctiva, applying either cyanoacrylate glue or amniotic membrane. Or if the patient comes with a perforation, we also resort to doing a Tenon's patch graft. Intensive topical steroids and oral steroids and immunomodulators are advocated. And in very severe cases, and even in one-eyed patients, we even switch to intravenous pulse steroids or cyclophosphamide or biologicals. So the management of PUK really depends on whether the patient has associated scleritis or systemic disease. And if the patient has, then really aggressive management is indicated and co-management with the rheumatologist. Once again, I would like to thank AIOS for giving me this opportunity.